Hi there, good afternoon, everybody. So it's just about 12:15, so we can get started with our provider COVID-19 briefing webinar. So welcome everybody, and thank you so much for joining in. I'm sure people are joining in from all over. We've had several of these webinars now, have gotten some positive feedback so far, and so we're really excited to be here and share our updates with you. So just as a brief introduction, my name is Dr. Fareen Karachiwala, and I'm one of the Associate Medical Officers of Health for York Region, helping lead case and contact management as well as outbreak management in the response. And we have a special guest with us today, which I'm very excited to introduce. So he is Andrew Lamb. He is one of our fourth-year medical students from the University of Toronto, currently doing a placement with us here in public health. So very happy to have him. He will be helping co-present with me, particularly for the topic of COVID-19 vaccine and giving an update of where things are at and the landscape of what's coming down the pipe. So that's great. And just before we get started too, I want to just do a big shout out and a thank you to everyone that's helped put this together. So for our communications folks, our corporate communications folks, of course, Brooke, Sarah, and Emily, who's part of the foundational team that puts the content all together. So thank you to you all. Next slide, please. So just a couple of quick housekeeping items. The meeting will be recorded and available later for those who want to check it out. There is an opportunity to ask questions. I'll have a slide on that in just a bit. We will try to answer the questions as we go through, and we do have some time blocked off at the end to address anything we didn't get to. And usually what we do is for anything that we just didn't have the time for, couldn't get to, we do keep a record of the questions and tend to send out in our updates later as well written responses to those. So feel free to ask questions. We know there's lots that's changing and evolving, so we will address as many as possible and provide a written response to those that we don't get to today. If there's any questions about the recording, the contact information is on the screen there. So next slide, please. Thanks so much. So if you're looking to ask a question, what you need to do is select the Q&A portion on the right side of the screen. So hopefully you can see that come up. You would just type in the question and then select send. You won't be able to see each other's questions, but we and the moderators are reviewing them as they come in. And like we said, we'll try to address as they come in. Great, so what we're going to be talking about today is a brief COVID-19 update. So just a look at the numbers, where we're at, what's happening with outbreaks. We will address several things that have come down the pipeline from the province and what's new. We are going to go over rapid testing because that is now becoming more and more available in Ontario. So I want to give some context around in what situations they're used and what that's all going to look like. And then Andrew, our medical student, is going to give an overview of the COVID-19 vaccine. There's been lots in the news lately about some promising developments. So we thought it might be helpful to give an overview of what's happening, what we know in terms of distribution timeline, which, as you may know, is not that confirmed, but at least a bit of an overview of what the vaccine types or the leading candidates look like. And then we'll do a brief mention on flu and flu update, since that is probably top of mind still for a lot of folks, given that it's end of November now. So next slide, please. Perfect, so we'll begin with the epidemiological updates for York Region. Thank you so much. So this is our current epidemiological curve. And you can actually see that into the fall, so September onwards, of course, we are into that second peak, and the magnitude of that peak is quite a bit higher than the first time around. Interestingly, the first time around, a lot of that was driven by our institutional cases, so people in long-term care, retirement homes, other congregate care settings. And then more recently, it's a lot of the community-based population, so doing a better job of keeping it out of the long-term care retirement home. And actually that has shifted the demographics quite a bit as well. So a bit of a younger population. A lot of the cases are less than 40 years of age, and also less hospitalizations and death rates than we saw the first time around. However, things are on the rise. And just for those folks that are interested in the exact numbers, our 7-day average daily new cases is now at 151. So we're averaging about 151 new cases every day, and that's been over the past 7-day period from November 24th onwards. Our rate per 100,000 is 69. Percent positivity, which I know folks tend to have interest in, so those are the people that are getting tested, what percent test positive, is 6%, around 6%, so quite a bit higher again than it has been. And our reproductive number is over 1. Hospitalizations and ICUs, they are on the rise, but we're being told by our local hospital partners that they're not at a critical juncture at this point. But there are more hospitalizations, again, not as much as we saw back in the spring, but that's still a concern. So next slide, please. So this is just a good snapshot of the types of outbreaks we are seeing currently. So as of today, and the slide is current, we have 1 child care center outbreak, 24 institutionals, 9 school outbreaks, and 17 workplaces. I know last webinar there was quite a focus on schools, so just a brief follow-up to that. I thought it would be helpful to talk about some of the trends we're seeing here in New York Region, but also provincially when it comes to school outbreaks. Again, the numbers of outbreaks and just even cases in schools have been going up since September. It was sort of manageable from sort of September, October, and then I'd say around mid-October, started seeing an increase in the cases and just number of outbreaks. I guess the good news part of this is the majority of our outbreaks, so around 70% or so, we're only seeing 1 or 2, 2 or 3 cases. And there's a select few where there are more cases, around 5 to 6, but for the most part, they are in that 2 to 3 range. Tends to be mostly elementary schools that we've seen here, and I think that's been mirrored as well in the province. So not widespread transmission. We haven't had too many school closures because of an outbreak. There's been the rare closure, and a lot of that has also had to do with operational and feasibility concerns and just the reaction from the school communities. So just so you know that is also going on. You may know that there is no current plan in Ontario to extend the school break. So we'll keep monitoring the situation and provide some updates on that. Next slide, please. So what is new from the province? Next slide. So as people may know from the news, I mean, this has been changing quite a bit, but York Region is in the red or control zone. So unlike Peel and Toronto, we're not in the gray zone, which is lockdown, we're in the red zone. And some of the provisions for what it means to be in the red zone are listed on the slide. So there is still indoor dining, for example, but a maximum of 10 people inside and only 4 at a table together. Capacity for religious services, weddings and funerals are there as well. And then the gathering limits are 5 people indoors and 25 people outdoors. In addition to this, our medical officer of health, Dr. Kurji, last Sunday issued a class section 22 order. And this section 22 order is specific to a number of different settings. So for example, meeting and event spaces, other businesses, establishments, banquet halls, as well as sort of retail and malls. Essentially what they have to do is set a capacity limit. So for stores, as well as malls and stores within those malls, they have to ensure physical distancing of 2 meters is maintained at all times, and based on square footage of their public areas and maintaining those 2 meters, they would set their own capacity limit. And we're doing quite a bit now by way of enforcement, so both proactive educational inspections, but also really following up to make sure people are abiding by the rules when it comes to retail and other businesses. And then banquet halls and event spaces, they will have to set capacity limits as well. And for banquet halls, they would have to, and event spaces, they'd have to be a maximum of 50 people at any one time. So there are links on the slides to what all this means, what the framework means, and what the provisions are for the class order. Next slide, please. So these are just some updated provincial guidance documents. In the interest of time, I won't go through it in too much detail, but probably most relevant for our providers is there is an updated primary care guidance document with some changes, particularly when it comes to case clearance from 10 days to 14. Next slide, please. Okay, and then a last thing that's new from the province is there's quite a bit of messaging coming out about the holiday season. And the reason we're presenting this to our provider group today is, of course, you are quite influential on your patients asking for advice and can help sort of reiterate the public health advice over the holiday seasons for anyone who's celebrating religious or other holidays. The advice is really, celebrating only with your own household and not people beyond those. Exceptions are for people who live alone to have, one additional household, but otherwise connecting virtually with people. And the same for shopping as well, virtual shopping, curbside pickup versus going into malls. Next slide, please. Okay, so quick note on rapid testing. I'm sure folks would be interested to hear this. So essentially what's rolling out across Ontario is point of care testing or rapid testing. So testing that's turned around in sort of a matter of minutes. There are several different types that are now approved by Health Canada. And in Ontario, we have access to 2 types. I'll show a little chart in just a bit. So there's antigen testing, which is one type, and then molecular or PCR testing, which is the other type. In general, they have a little bit lower sensitivity than our gold standard PCR. Or lab-based testing, and so typically are used for screening or surveillance versus diagnostic purposes. And interestingly, in Ontario, you might have seen in the news as well, an 8-week pilot is being rolled out for workplaces. So these are asymptomatic workers, low pretest probability, no other risk factors for, they're not an outbreak, they don't have links with confirmed cases. To see what's happening in that worker population and to help evaluate the rapid testing. So there will be this parallel testing as well going on. So anyone that gets the rapid test will also get your usual PCR lab-based test to just evaluate performance. Next slide, please. And so this is a helpful table to sort of see the differences. So these are the 2 types of rapid tests available here in Ontario. So there's the Abbott ID Now, which is the antigen, our molecular RNA PCR, and then the PanBio, which is the antigen test. It's the PanBio that's predominantly being used for this 8-week workplace pilot. The Abbott Now test, you'll see it has nasal throat NP versus NP, so these are both still requiring somewhat more invasive techniques. You can see the turnaround times and cost associated with those. The Abbott Now molecular test, that's mostly going to be rolled out in rural areas, Indigenous communities, places where lab turnaround times might be very high, and then including a few pockets in Peel and Toronto where, of course, the transmission rates are quite high. And then PanBio, like I said, is the antigen-based testing more for screening and surveillance. That will be used on workers. So basically an organization can apply to the government to get access to these kits for free and then test workers and be part of the pilot to see what all results. Will have very interesting implications depending on the evaluation of all this for, possibly testing in long-term care homes where you want a more immediate result. Possibly in schools. I think it'll have a big impact on, say, homeless populations or places where we need to know an answer a lot quicker. So it will be really interesting to see where that goes. Next slide, please. So just a quick note on the management of individuals with positive test results. Again, there is this parallel testing going on, so everyone with the rapid test will be getting the gold standard as well, or should be within 24 hours. And then depending on the results of both, public health will advise whether we believe it's a true positive or not. We are treating anyone with a positive rapid test as a probable for now, so we would initiate contact tracing on them. And we would ask that if anyone gets these results as well, there is still mandatory reporting to public health as a positive result, and we have our contact information at the end there. So just a note on that, and next slide. Wonderful. So this is just a quick snapshot because I know there's lots of different criteria now and settings for testing. So our assessment centers are still seeing, our symptomatic people with risk factors and probably the broadest catchment of people who need testing. The pharmacy is seeing asymptomatic people, and that is expanding as well in terms of the number of sites being offered. And there are people with some risk factors or sort of populations of interest, but they remain well. And then this workplace screening pilot with the rapid test, again, is mostly for workplaces who are, well populations, no risk factors, to help evaluate the pilot. Next slide, please. This is just a few resources related to the rapid testing in case you're interested in more thorough guidance document and what that all looks like. Next slide, please. Perfect. So before I turn it over to Andrew, I'm just going to address the one question I do see here about senior citizens who live alone. Can they merge with other households? What is the bubble guidance now? Yeah, so actually the province has stuck to the sort of bubble guidance, but I think a lot of our local places, including here in New York region, are saying not to go beyond the household because we're a red zone, and Peel and Toronto are saying the same because of being in a gray lockdown zone. The only exception, as I mentioned briefly before, was if you are somebody who lives alone, so perhaps you are a senior, then it's okay for those like essential social supports to merge with another household and have limited contact with people beyond your household, but otherwise really asking people to remain within their household bubble. So I'm going to turn it over to Andrew, our medical student, to give an overview of the COVID-19 vaccine developments that are relevant. And thanks so much.
Thank you very much, Dr. Karaczwala, and thank you to the team for your support on the slides and the presentation here today. So I'll be going over some of the updates from the COVID-19 vaccine front. If I could go into the next slide, please. So as we know, globally, there are a lot of efforts that are being done right now to develop a COVID-19 vaccine, and work is taking place at an unprecedented rate that we haven't seen prior. Overall, there's more than 130 candidate vaccines that are across different stages of preclinical trials and clinical trials that are being developed by both academia and in partnership with industry at times. We've included a link to a landscape document provided by the WHO here as well. Next slide, please. Within Canada, we know to date that the federal government has signed advanced purchase agreements, or APAs, to secure up to a total of 358 million doses of the COVID-19 vaccine from 7 different developers. And there are embedded in these APAs options to extend and acquire further doses as they become available. As of November 18th, there in Canada is one active anti-SARS-CoV-2 vaccine candidate within our own nation, and that is being conducted by Medicago Inc. in Quebec. And presently, there are 3 international COVID-19 vaccine developers which have applied for an expedited review under the federal interim order. So that is a new order that the government has placed in just to have a more expedient process for approving vaccines that have been prepared or developed and researched elsewhere. And so the 3 candidates which have applied for this review include Moderna, Pfizer and BioNTech, as well as AstraZeneca. And I just want to add here that between Moderna and Pfizer, which I will talk more about in just a moment, these 2 developers make up to 76 million doses that the government has an APA with. And for AstraZeneca, that is another 20 million doses. Next slide, please. And so presently, the 2 main candidates that I'm sure many of you have heard about by now are Pfizer and Moderna's vaccines. And both of these are based on a messenger RNA or mRNA vaccine. And this is a new type of vaccine that's being, well, it's been researched before, but it's newly being used to develop vaccines for infectious diseases. In between both of them, this table nicely outlines the similarities and differences for them in that the Pfizer and Moderna vaccine both have mRNA to create the pre-fusion spike transcript on the coronavirus. In terms of the Pfizer vaccine, we know that it's been trialed to have 2 doses that are set to be 21 days or 3 weeks apart. And from their clinical trials, they've noted that there have been 162 cases of symptomatic disease in the placebo group versus 8 in the vaccine group, leading to a vaccine efficacy of 95%. So that is the proportion reduction in disease among the vaccinated group. When looking at the senior population age 65 and older, the vaccine efficacy is 94%, which is very comparable. In terms of storage for the Pfizer vaccine, one of the challenges we know is that it requires a very cold temperature between -70 and -80 degrees centigrade for it to be stored up to 6 months. It can be refrigerated for up to 5 days, and at room temperature, the vaccine will persist and last for several hours. In terms of the Moderna vaccine, it's also a 2-dose vaccine that is set 28 days or 4 weeks apart. And from clinical trials, we know that there have been 90 cases of symptomatic disease in the placebo group and 5 in the vaccine group, leading to a vaccine efficacy of 94.5%. There has been no difference found in the efficacy between age and ethnicity for the Moderna vaccine. And in terms of storage, for Moderna, it is at -20 degrees centigrade, in which it can last for up to 6 months. So a little bit different compared to the Pfizer. We don't need an extreme cold chain management there. And in terms of refrigeration, it can last for up to 30 days and at room temperature for up to 12 hours. And one piece I should also add for mRNA vaccines as well. One of the advantages compared to other vaccine types that we know of include the fast manufacturing processes that are available with this type of vaccine. But one of the disadvantages, as we've come to see as well, is that the supply chain materials can be quite unstable, which is why these vaccines require storage at colder temperatures, for example, up to -70, -80 for the Pfizer vaccine. And we know that the side effects so far from the phase 1 trials have been fairly consistent with those of the flu vaccine. I don't have the AstraZeneca vaccine listed here, but I know there have been recent updates, and I just want to say that further investigation is being done. I know the protocol is being discussed and reviewed in the scientific community, as there have been consideration about some of the implementation processes that they had conducted. Next slide, please. So some considerations to have with these COVID-19 vaccine candidates. From the 2 clinical trials for both Pfizer and Moderna, pregnant women and children under the age of 12 haven't been included. In Pfizer, they recently included children in their investigational studies in the recent months. We do know that there's similar efficacy for both of these vaccine candidates, which helps simplify the distribution process when we do acquire the vaccines. One interesting piece that was noted is that there's insufficient data right now to suggest whether the 2 vaccine candidates can reduce the acquisition of infection. So what this means is we're not sure whether persons who get infected after vaccination, if they are still infectious to others, can they be asymptomatic carriers? We know that with the high vaccine efficacy rate, that it reduces the symptoms or eliminates it. But the evidence isn't yet available in terms of the carrier status. To address that, there's an ongoing vaccine safety and monitoring process from both the developer side as well as from federal agencies that will be authorizing these vaccines to monitor any challenges and adverse events. And critically important as well is to have the support from healthcare providers to report any adverse events following immunization. There should be continued consideration and reinforcement of public health measures, such as face masking, physical distancing, and good hand hygiene, even after a vaccine is available, to abate any behavioral disinhibition, as individuals in the community may have a perception that the vaccine prevents them or prevents transmission within the community. In terms of planning for distribution and allocation, there is the National Advisory Committee on Immunization, or NACI, that has been looking into an efficient, effective, and equitable approach to doing this. If you go into the next slide, please. So some of the key populations that are being looked at include individuals who are at high risk of severe illness or death from COVID-19, those who are likely to transmit COVID-19, as well as essential workers who are maintaining the COVID-19 response, those who are contributing to maintenance of other essential services for the functioning of our society, and those who are living in conditions predisposing them to an elevated risk of infection and disproportionate consequences from infection. And this includes Indigenous communities and other minority groups. If we can have the next slide, please. In terms of the distribution for COVID-19 vaccine in Ontario, we know recently the province has set up a task force that will be chaired by General Rick Hillier, who will advise as a group on the delivery, storage, and distribution of the vaccines. As of yet, it's still in early stages, and so our predictions are that release of the vaccine and distributions will come in phases and would target the high-risk populations that we just mentioned previously. And what usually would happen is the OGP would be the distributor of the vaccines, much like the other vaccines. And the idea and hope is that there would be a multi-pronged approach to administering vaccine to as many people as possible in as short of a time as possible. And so we imagine there will be many distribution points, but we don't know this for certain yet. We will keep you up to date as we learn more. And next slide, please. And so as a healthcare provider, you play a critical role and a very influential one in terms of keeping our community safe. And part of that, as we mentioned, was reporting the serious adverse events that follow immunization. And so embedded in this presentation are these links, which you can follow directly to the forum and for further guidance as well. There also is more now than ever concerns about vaccine hesitancy and what that may mean for the patient and for the community. And so it's critically important to continue those messages you convey to patients on a regular basis, as well as continued promotion of public health measures. Next slide, please. So for this next section here, I'll provide a quick update on flu and the status in our communities. This is a very positive graph that we have on the screen right now. So on the right side, we see the current influenza season. We're at week 47 right now, and we're not seeing any cases of influenza. Compared to prior seasons, we would expect between 6 and 8 cases of influenza on a weekly basis at this point. And this really demonstrates to us that the public health measures in place right now have helped keep the number of influenza cases low. In terms of stock, we are out of the high dose flu vaccine, and we are in low stock of the quadrivalent vaccine. For the flu mist, we will be receiving a limited amount sometime over the next week. And so stay tuned for any messaging that will come out once we receive a shipment. But in the meantime, please do continue vaccinating with whatever you have. Next slide, please. So we're now entering into the Q&A period, and I'll ask for Dr. Kharichwala to join us once again. Thank you.
Wonderful. Thank you so much, Andrew. Thank you for that very helpful overview. So we are into the Q&A period, and I do see some questions that have come across through the live event Q&A. Before we get started with that, though, I just want to give a quick plug. There is a quick survey we have. You can see the link in the Q&A chat box there. So it would be really, really appreciative if everyone could click on that. It's just a few very brief questions. We're just interested to know the utility of this type of webinar, if you would participate in the future, and just where everyone is coming from. So it would be very, very helpful to us. It would take just a couple of minutes. If you could do that anytime now, that would be perfect. Thanks for that. And then just a couple of notes about what was said, and then we'll get into some of the Q&A. So I just want to really reiterate what Andrew said as well in terms of the healthcare provider role in promoting COVID-19 vaccine when it's available. We know that there's lots of vaccine hesitancy out there, and for many reasons, you know, that may be more prevalent potentially for COVID-19. You know, RNAs are sort of a newer type of vaccine. People may be reluctant. We also know in the evidence and the literature that a healthcare provider's recommendation is probably the single most important thing that people listen to when they're trying to decide whether or not to get a vaccine. So, we thought it was really important to give an overview, more information to come, of course, when we know more, especially about the distribution pathways. But I think the more that healthcare provider can support in that recommendation, the better it will be for all of the public health response. And like Andrew said, we don't know too much yet around the distribution side of things and what that's going to look like. Typically, with these types of things and what's happened in, say, H1N1, though, the scope of that was, of course, not comparable, is that public health typically has a role when it comes to vaccine fridge inspections and distributing. And then we're hoping, or we're thinking that the Ministry of Health will rely on as many vaccination administration points as possible. So whether that's pharmacies, primary care offices, likely public health will also be doing some mass immunization clinics. People are preparing for that. Again, we don't know what this is all going to look like, but those are some of the ways it might go. I guess the other thing is that it might be multiple types of vaccine that are rolled out all at once. There could be a limited supply, as Andrew said, for just a few important subgroups of people first. And when there's more limited supply, public health tends to take on a bigger role in distribution and administration. And if there is eventually a larger set of supply and availability, then we may end up being more of a distributor role with the providers being administrators. So all this is being looked into, and there's lots of planning tables that have been struck up. You might have heard about one recently. And so lots is going into the planning of this. As soon as we have more updates, of course, we will also let you know. So I'm happy to get into some of the questions that I'm seeing on the chat group. So I see one person asked about the gathering limits. So in physician clinics, for example, where there's 5 to 7 staff, how many patients are allowed in, and do those gathering limits of 5 people indoors apply to physician offices? This is something we have inquired with the Ministry Emergency Operations Center, and in the regulation, healthcare government administration services are exempt from those gathering limits. So what the providers or primary care providers, for example, are bound to is that primary healthcare guidance document. So that's what we put a link to in the slides. It's been updated more recently, and there's a lot of provisions in there around screening your patients, around maintaining physical distancing in the office, which is of course still a requirement and important. But those exact limits of the 5 doesn't apply to healthcare services. The other question I'm seeing here on the chat box is how long after somebody's infected with COVID-19 will their test turn negative? So this is a really good question. So in terms of actual infectivity, like how long are you shedding a viable virus and can keep passing that on to people? We know that's about 8 to 10 days, and that's the rationale for the province changing their criteria so that a case is now considered cleared or no longer transmissible 10 days after symptom onset instead of that full 14. So the incubation period of if you're exposed and you have to stay in self-isolation, that remains 14 days. But if you yourself are actually a case, we know that you no longer have viable virus that can spread onto others after 10 days. The only exception to that is if you're severely immunocompromised, and certain other limited criteria, but for the most part, for most people, it's 10 days. In terms of how long the test keeps picking it up for, it is a pretty sensitive test, the RNA. And so we've had reports that 90, 110 days after a positive, you could still be picking up dead virus because it's such a sensitive test. So we encourage people who are cleared already of the virus not to get retested. Unless there is a re-exposure or new symptoms, we don't ask that people get tested again. There's only been, I think, 6 cases worldwide of reinfection, and those have all happened. I think at the average, we're just talking about this, is about 45 days after. But again, the picking up of the dead virus could happen up to 3 months after, and even then some. So I see some other questions here as well. So York Region is a huge area. Is there any more detail regarding where in York Region the cases are coming from? So yes, we have a breakdown of our 9 municipalities. And for the most part, our rates are the highest in Vaughan, Markham, Richmond Hill, and sort of our southern municipalities. The northern 6 tend to have a lower rate. If you go on our website, which is york.ca/COVID-19 data, our dashboard is publicly available, and you can actually break it down by most municipalities and can actually see the rates as well as counts for each one. The northern 6, I believe, are grouped together, so a little bit harder to tease out for that. But we do know that there are certain areas, mostly in the more densely populated areas in York Region, where there is more community transmission. Great question. I believe we have till 1, so I may just keep answering some questions, in which case. One is, how is York Public Health getting data about flu cases, and specifically the number of flu cases? So this is a great question as well. Testing for flu tends to be limited, as it has in previous years as well, to hospitalized inpatients and people in long-term care homes. So if someone's hospitalized, if they're in long-term care and flu is suspected, the test is done, and then it's mandatory reporting to public health. So we do keep track of all those. Not everybody who might have flu in the community is picked up, so that would be an underreport. But there is also sentinel surveillance of specific sites where we do record community flu cases. So it's pretty good data coming in from different angles. And again, we're comparing to last year. And what we're seeing is pretty consistent with what was seen in the Southern Hemisphere as well when it comes to flu, which is better rates. And so the thought is that less virus is circulating because of all of the public health measures in place as a result of COVID-19. So I'm just scrolling here. Oh yes, there's one earlier question. So does public health always contact those who have had COVID contact? So I guess those who are contacts of COVID cases that require self-isolation advice, or does the workplace sometimes notify patients? So if they're notified by a workplace, should they be COVID tested? And is this contact tracing? So yes, York Region Public Health is back to full contact tracing. We are making contact with all people requiring self-isolation advice as a result of being in close contact with a confirmed COVID-19 case. Sometimes we'll rely on a workplace or establishment to send out notices in collaboration with us. So usually if we've asked a workplace or somebody else to do that self-isolation advice does hold true. If people ever have any questions about that, they can always call in to our Health Connection line, and we'll put some numbers up at the top there right at the end. So that can always be done, but public health is doing contact tracing and following up with all close contacts of confirmed COVID-19 cases. Okay, so I'm just taking a scan here. All right, so somebody else has asked, how necessary is eye protection? So this is a good question, sort of depends on the context. Mostly I'll speak about it in the setting of healthcare, given the audience today. So the recommendation is, if you are caring for anyone with suspected or confirmed COVID-19, you're within 2 meters as a healthcare provider, then yes, you would be wearing a surgical mask, eye protection, as well as gown and gloves. The face surgical mask and the eye protection is more important probably than the gown and the gloves. Important hand hygiene is also important. We usually would consider somebody who's a healthcare provider a close contact requiring self-isolation if they were for a prolonged time within 2 meters without that eye protection. It does depend on a number of different factors, so whether that patient was actually symptomatic at the time, whether there was any contact with fluids or respiratory secretions, and the rest. So it tends to be an individualized risk assessment. But we are saying if you're within 2 meters of a suspected confirmed case, then yes, eye protection is quite necessary. So that's a great question. Just taking another quick scroll through. Okay, yes, there's one great one here too as well. So I was wondering how to improve distribution of vaccines. We got flu vaccines late compared to pharmacies. Many of our patients, mainly elderly people, got their vaccines in other places. So that means the vaccines that we got late might be unused and wasted. And this happens, several years in a row. Wondering if there's a way to help with this issue and avoid vaccine wastage. Yeah, it's a really good question. The whole process of getting flu vaccine year after year is a very complicated one. What happens is it's actually ordered federally, and then the provinces and territories decide how to divide it up. Ontario is one of the few provinces with a universal influenza immunization program, meaning that everyone that is eligible basically gets it for free. And so the demand here is quite a bit higher than in some other provinces. But that's not always accounted for when the distribution among provinces and territories happen. So there's usually a bit of a mismatch between demand and supply. And how it gets rolled out, it's different in different health units. We will get it from the Ontario government pharmacy and then distribute it to holding points. The pharmacies tend to have their own channels for distribution and can sometimes get it first. And then because of accessibility, longer hours, things like that, people do tend to get it a bit more. We've seen the proportion of people getting their flu vaccine in pharmacies really rise over the past several years, so that's definitely happening. The issue of wastage, yes, is concerning. I think we were thinking that folks that go to providers, because pharmacies can't vaccinate everybody, there's certain age cutoffs and things like that, and hoping that those vaccines could still be directed to those other people who are not getting it, or mass clinics that other providers are doing. I think just recognizing this tends to be a concern, and we're sort of always thinking through ways it can be done better, but recognizing that the actual procurement and distribution, a lot more control is had sort of provincially and nationally versus at the local level. But if there are ideas from providers, we're always sort of open to hearing about them, but do recognize it is a challenge year after year. Absolutely. All right, so we just have a couple minutes, so the rest of the questions, there's not too many, but we can address them in a written format. I do want to just draw your attention again to the link to the survey. If you could just take a minute or two to fill that out, it would be really, really helpful for us. And I think we have a couple of other quick reference slides and contact info. Thanks, Brooke. So additional resources. Yes, please do complete the survey. Thank you so much. This is our website, york.ca/health professionals. There is a tile on COVID-19. Please do sign up to our e-newsletter. You can see it's circled there. It's a good way to get the compendium of questions and answers after this webinar, and easy links to our webinar and future ones. So please do use that. Next slide. A couple of links that are helpful to bookmark in case you're looking for up-to-date guidance documents and the rest. So there's some for the ministry, PHO, and ourselves, of course. Next slide. This is our phone number. Should you have any questions, there is a dedicated health professional line, so feel free to call. And there is an after hours number as well for sort of reporting purposes. Next slide, please. Oh, that's it. Yes, so thank you so much. Do sign up for our e-newsletter. We will follow up with those Q&As. I believe we'll be foregoing our webinar in December given the holidays, but resuming in January. And again, looking very forward to the feedback on the link. If you could please fill it out, it would be really helpful. So thanks again for tuning in. We hope that this was helpful, and stay safe, and thank you for all you're doing. Take care.